Alicia, I got to go back to you because you're doing so much great work in this. So talk to us a little bit about some of the tools, questionnaires, and work and that's ongoing now in this whole field of having us better assess neuro-oncologic impact.
Sure. So I think the International Society of Geriatric Oncology really set us up well for these kinds of assessments a few years ago, and their recommendations are published in European Urology. This is an international group of experts. Some are prostate cancer oncologists, some are neurologists, geriatricians that got together and said, you know, you are putting patients on these therapies for years. These are elderly patients who have comorbid disease and who are at risk because they age every day of having these complications that are associated with aging. So there's a very brief assessment called the G8 that they've recommended that we think about, which assesses nutrition, functional status, as well as polypharmacy and very briefly cognition as well, that we could think about putting into our practices, as well as something called the mini COG, which is 3 questions. It takes less than 5 minutes to administer, can be done by an MA, that is a way to briefly assess cognitive function. But in reality, it's really hard in clinical practices to get all of these things done. And although these have been outlined and seem reasonable, they are very basic screening tests that if you uncover something on any of these, you actually end up having to send it to a specialist to really do an in-depth neurologic evaluation or an evaluation of potential social services that may be helpful, or physical therapy, or whatever the deficit is. So we are really at the beginning stages of trying to understand this. I think even asking a patient about his fall or his bruise, or asking a patient or caregivers who will sometimes give more information, you know, how are you feeling? How is your mood? How are you getting around? What does your day look like? These kinds of simple questions can help us really identify sort of cracks in their facade, because patients usually come in telling me, I feel great, I feel fine. But if you start picking at certain things, even saying, how are you thinking? Are you still thinking as clearly? How's your memory? These little things, sometimes patients will answer in a way that even if they say, I'm fine, there's some ambiguity there that you can dig into and find that there are problems. So it does start with us, whether it's a standardized assessment, which is ideal, because if you ask everyone in a standardized way, you'll probably uncover the most problems, or just kind of following our intuitions and hunches and asking these basic questions around how are you thinking, how are you feeling, what's your day look like, we can start to uncover some of these issues.
Pedro, how about yourself in terms of, these patients who come into your really busy clinic, they could be in the VA, they could be in outlier clinics as well as in the Metropolitan Health Center. How are you thinking about not only tolerability of these drugs, but proactive ways of better, working through their ADT, their AR inhibitor vis-a-vis their neurocognitive impacts? Any kind of strategies?
So, I usually go back to Alicia and others work on that, to help me in terms of safety signals and kind of red flags that I'll have, right? The question is, if you don't ask, you won't find out a lot of times, right? And even when we conduct these really nice studies, the discontinuation rate was close to 10%, right? Which tells us that for most patients on these medications, they'll be doing fine. There's a subset of patients that won't, unfortunately. And the question is, can we really identify who those patients are? Are we paying enough attention to them? And I think that's critical, right? And perhaps when that happens, rarely, but they are real nonetheless, those are real patients, sometimes we have to consider discontinuation of medication and think about ways to improve their impact in the neurocognitive system, for instance, right? We talked a little bit about cardiovascular impact, and now we're talking about the neurocognitive impact. So those are real. I would argue small, but real nonetheless. I'd just like to make the point in terms of efficacy. I think we all stress out the point that really, we're talking a lot about treatment intensification, right? Moving these agents early on. And so whether we use a fancier scan and we diagnose metastatic disease sooner rather than later or not, the reality of it is what's going to change is, are you going to start them with an anti-androgen on top of ADT, or are you going to debate with a CYP17 inhibitor instead? But the reality of, no matter how you see it, and Alicia just mentioned the press release that came for Dura-Enza in terms of survival benefit, and we all predict that we are about to see the same with apalutamide. So I think it's across the board when we kind of take a step back and look at this as an overall picture, and thinking that unfortunately a lot of these patients will progress. So we are not aiming for cure, but we are aiming to control the disease, to make prostate cancer as a chronic disease as much as we can. Unfortunately, most of these patients will face mortality. And so, and it's always a difficult balance between what can I do to help them live longer and at the same time preserve quality of life as much as I can.
Yep. I think that's a really important point, because I think, as William was mentioning, his patient didn't even want to mention that tripping might have anything to do with the medication. I find that my patients don't want to tell me that there is a side effect, many of them, not all of them, but they don't want to tell me about things because they don't think they have any other option. They say, well, you put me on this to make me live longer, and I want to live longer, and I guess I'll just have to put up with this. And one of the good things about having multiple drugs, you can actually switch between them. And let's say someone did fall or is a little bit more sleepy or more confused on one drug, and maybe if you switch to darolutamide that doesn't cross the blood-brain barrier, maybe they won't have as much of a problem. And I've seen that that's true. And the patients are really happy to know that they might have another option, so that they can tell you something's wrong, you don't have to tease it out, and that, well, we could, as you said, try a lower dose or try a different drug. And once they realize they might have another option, that's also very important, and allows them to feel more comfortable telling you that this drug you've given them to save their life, there might be another one you could try instead.
I think it's a great point.
I do want to emphasize the importance of the overall survival benefit. We haven't seen the data yet, but it wasn't always intuitive that if you use a drug earlier that you're going to live longer. So to me, it's extremely powerful. I mean, MFS, I think, is a clinically meaningful endpoint, but as I mentioned earlier, you're giving patients 2 years or more of additional therapy, and you're preventing a metastasis. But if in the end they all die at the same rate, then have you really used these drugs for the purpose of allowing them to live longer? And I agree with Nancy that patients want to live longer. Of course, they don't want to live badly, but in the end, they want to live longer, and we want our patients to live longer. So it's quite powerful, because these drugs have been around. Drugs like enzalutamide and abiraterone have been around for many years now for the metastatic CRPC setting. So shifting them earlier and still being associated with an overall survival benefit, I think is a very powerful statement that earlier use of these drugs is really meaningful in terms of OS.
Yeah, I think this was a big deal. There were press releases. We haven't seen
the data yet,
but they're going to be presented. And so Prosper and Aramis, darolutamide and enzalutamide respectively, have said they not only made MFS, but they've now reached the secondary OS endpoint. And so I think it's really a big advance. Like you said, I suspect apalutamide will as well, and by the end of the year.